imaging. He has obtained advanced musculoskeletal radiology training in USA and completed various fellowships on cartilage MRI. I would like to specially thank Sir for taking time out and accepting the invitation on really last minute. And I'm so sorry for the background noise.
No, no. Thank you, Ankita, for your kind introduction. So we'll be starting with the MSK imaging. I just wanted to keep this topic as it is not focused on any specific area, but this is just more of how we face the issues in day-to-day reporting, or what are the mistakes that we all tend to make during our everyday reports that we make. I hope I'm audible.
Yes, sir, very
Okay,
clearly.
okay. So just like the seven wonders of the world, I'll be sharing with you seven dilemmas of the MSK MRI that we face every day. To start with, first of all, many of the times you all must be getting MRI shoulder request, and we don't find anything abnormal on the first go whenever we see a shoulder MR. So when you don't find anything abnormal and the patient is having, particularly a young patient who is having pain or difficulty in shoulder movements, and just like this, we find the rotator cuff is intact, there is no other abnormality in the shoulder joint, then the question comes what to do next. Just this is the coronal plane. I'll show you the other images as well. So this is the same patient. If you look at the axial images, or let us have a look at the coronal images first. The acromioclavicular joint is showing some minimal changes, but the rotator cuff tendon is primarily intact. There is minimal fluid, which is also normal, but not finding any obvious abnormality that would suggest or that would be responsible for patient's pain. So whenever you find such kind of abnormality or such kind of patients, have a more closer look at certain specific areas. Like here, if we go from cranial to caudal in axial, then uh, keep looking at the labrum, and many of the times you might see subtle areas of labral tears. And particularly here, if you look carefully at the anteroinferior part of the labrum, there is definitely a tear. Whenever you find an anteroinferior labral tear, we know that it commonly occurs with the shoulder dislocations. So many of the times, this patient may not clearly give you history of shoulder dislocation. They might be having some history of jerk or some injury in the past. Again, that was probably in the some before some months. So there are no acute changes, but what we see is the changes are they might have happened before some time. And go back to the part of the area of the superior part of the head of the humerus, which is the classical location for the Hill-Sachs fracture. That is the posterolateral aspect of head of humerus superiorly, particularly when we see at the level of coracoid. Here we are just, if you can't see coracoid almost up to the level of head of humerus, then at least see in the superior part or upper 1/3 of the head of humerus, you might see some areas of cortical flattening or depression. Again, when the changes are chronic, you may not see any marrow edema. Even sometimes when you have doubt on MR, can take help of CT scan, and that sometimes might show you those subtle areas of cortical flattening better, like here. Now, if you see, it is at the level of coracoid, and there is a small focal wedge-shaped depression of cortex at the classical location of posterolateral aspect of head of humerus superiorly. And that is a small Hill-Sachs fracture, and there was associated a focal labral tear at the anteroinferior aspect. You might see some rounding of the glenoid, but there is no fracture. So these are the changes which you might see in many of the patients who present with some shoulder discomfort, but they do not have any other findings in the rotator cuff. But we need to look, or we need to specifically search for these findings. If we don't search, we might be completely miss it and pass that MRI as an insignificant MRI, or may not be showing significant changes. But always be careful before you stamp any MRI as normal, particularly in young individuals, to have a closer look at the labrum, and particularly the anteroinferior labrum or sometimes even anterosuperior labrum, to find those subtle changes. So shoulder dislocations, they sometimes present in very bad way, which is where it is very obvious, like here. You can see the shoulder is dislocated, even impacted. The humerus is displaced anteroinferiorly, and there is an impaction of the head of the humerus with the glenoid. But every time it doesn't present in this way. Most of the times what you will see is the changes will be very subtle, and you might have to look very carefully to identify those changes. The second important thing, as soon as you find those Hill-Sachs and Bankart, is to give surgeon more detail, because now they are not satisfied by just your diagnosis of Hill-Sachs and Bankart. So what we need to tell them is whether the lesion is on track or off track. That is whether it is an engaging Hill-Sachs or it is a non-engaging Hill-Sachs. And how do we do that? There is a concept of glenoid track and the Hill-Sachs interval. So once we do the MR, we need to find out what is the Hill-Sachs index, that is the length of the Hill-Sachs fracture. If the fracture ends posteriorly, then you might need to add this probably 1.5 millimeter to reach up to the insertion of the infraspinatus tendon. But many of the times it might be reaching up to the insertion of infraspinatus tendon, and then you can, in those cases, you can directly take this measurement as the Hill-Sachs interval. Right? So this is the Hill-Sachs interval, and then calculate the glenoid track. How do we calculate that? On the oblique sagittal images where you can see the end on glenoid, draw a best fitting circle and then measure the glenoid track, that is the diameter of this circle multiplied by 0.83, because it is from the various research, it is concluded that the entire glenoid does not contribute to the glenohumeral joint mobility. Only 83% of the glenoid is responsible for that movement. And so you multiply it by 0.83 and then subtract the part of the fracture from that, or the part of the rounding of the glenoid from that. So what we get ultimately is the glenoid track. Can also measure the glenoid bone loss. So these are important to understand whether it is a engaging lesion or it is a non-engaging lesion. Take into consideration the Hill-Sachs index and the glenoid track. Ideally, whenever the Hill-Sachs index is, for example, here it is 10.7, the glenoid track is still 13.8. So when the glenoid track is larger, it suggests it is a non-engaging lesion. If the Hill-Sachs index is larger, then it suggests that it is an engaging lesion. So as I said, look for those subtle Hill-Sachs, the subtle areas of the anteroinferior labral tear, which you might miss on the first look, but that is responsible for patient's pain, and that is the entire complex of Hill-Sachs lesion with Bankart. Sometimes with gradient sequences, you might be able to appreciate those subtle Hill-Sachs fracture better. And as I said, you can take those measurements either on MRI or CT scan, and we can uh, identify whether these lesions will be engaging or not. What is engaging is when it dislocates. If it gets impacted like here, that is an engaging. When it does not get impacted like here, that is the non-engaging lesion. Right. So these are the more stable lesions. These are the unstable lesions, and patients who are having off-track lesions, the surgeon might have to do glenoid reconstruction also along while they operate those patients. And that is why it is important for us to tell them beforehand that this is probably an engaging lesion, so that they can plan their surgeries accordingly. You can find multiple articles which describe very nicely the on-track or off-track lesion and how to do all those measurements. So as I said, look for the porthole and the car. If this is smaller compared to the base of the car, it won't fall off. So that is a non-engaging or on-track lesion. But sometimes what happens is either the Hill-Sachs interval is too large, then the glenoid track, though the glenoid track is of significant size, but this interval is much larger. So again, it will become an off track. Or sometimes when the glenoid, uh, the Hill-Sachs interval is smaller, but the glenoid interval is even smaller. The glenoid track is even smaller. Still, it will become an off-track lesion or uh, the engaging lesion. Right. So that is about the Hill-Sachs and Bankart, which can be subtle. The other abnormality which you might come across many times is these areas. So you might see subtle areas of hypointensity in the supraspinatus tendon. Again, the tendon may be intact. You might not see any discontinuity of the tendon. Only abnormality that you will see is such hypointensity, and that suggests it is a foci of calcification. You will see it as hypointense on both the T1 weighted as well as the T2 weighted images. And this is the areas of calcification which forms the calcific tendinitis, and they can be a reason of patient significant pain. Again, you can take help of gradient where it might show blooming, and you will be able to appreciate it very easily. But look for these areas of hypointensity before you pass off that MRI as a normal. Here the areas are little larger, but they can be very subtle, like here, like this case, and you need to look carefully to identify those subtle areas of calcification within the supraspinatus or infraspinatus tendon. That is the supraspinatus calcific tendinitis. It is also known as calcific tendinopathy. We know that it occurs because of the deposition of the hydroxyapatite crystal, or HADD. It is self-limiting but very much painful condition because of this deposition in the tendons, and most commonly it affects shoulder. Sometimes you might see it in the hip and knee joint also. And supraspinatus tendon is again most common site for calcific tendinitis. One more condition that I would like you to remember before passing off any MRI as no as normal is this: whenever you get a patient who presents with probably complain of pain in the action of throwing kind of action, particularly a young patient or sometimes even elderly, this is just a subtle calcific tendinitis that you might need to see carefully to identify so that we can make the proper diagnosis of calcific tendinitis. Uh, if the calcific tendinitis, sometimes the calcification can go within the bone also, and it can result in so much of marrow edema. So that is the calcific tendinitis, which shows intraosseous migration and results in significant bone marrow edema at the site of its insertion. Other thing which I was talking is the patient presents with pain, which is particularly in the throwing kind of action. And again, you don't find anything abnormal on the first go, but look carefully for the labrum, as I said, sometimes anteroinferior. If not, then look for the posterior-superior labrum also. So you might see here the posterior-superior labrum is showing areas of hyperintensity, and that is the site of tear of the posterior-superior labrum. There is a focal tear of posterior-superior labrum. In addition to that, you might see additional changes either in the supraspinatus or in the conjoint tendon. These are the minimal changes of tendinosis in the conjoint tendon. And associated with that, there are small areas of cyst-like changes in the head of the humerus. So when you see combination of all these three, this favors the diagnosis of internal impingement. This is a condition when patient presents with pain, and again it is specific in the overhead movements. And when you see areas of undersurface or supraspinatus or infraspinatus tear, or sometimes tendinosis, there can be a posterior superior labral tear or fraying, and cyst-like changes in the posterior aspect of head of humerus. All these three together, they form this complex of the which is classically seen in internal impingement. So this is the labral tear, the areas of cyst-like changes, and there is a small partial tear of the conjoint tendon. That is the internal impingement. Again, these changes can be very subtle, and unless you look carefully, you might miss those changes and pass it off as normal. So to remember, when the pathology does not look at you, you have to look for the pathology. And when the shoulder looks normal on first look, please have a detailed look for the Hill-Sachs lesion, for labral tear, for Benkart lesion, for calcification, subtle areas, or conjoint tendinosis and tear of the posterior superior labrum. Ask for history of shoulder dislocation or any jerk or any instability. Ask for history of pain, which could be severe and acute on chronic in cases of calcific tendinitis, and ask for pain while throwing action or throwing kind of movement, and that will help you in diagnosis of the internal impingement. So these are the things to remember when the shoulder apparently looks normal. Second dilemma is many times we see areas of bone marrow edema at the unusual site or unexpected location, or you might see that persistent marrow edema on follow-up on multiple scans. Like here, young patient presented with left-sided hip pain. There's an effusion in the left hip joint with marrow edema in the neck of femur. Somehow somebody initially reported this as a synovitis with possibly infection, a tuberculous infection. Patient was put on AKT, and when came to us on follow-up, it was exactly the same picture. There was no improvement at all. Similarly, you might see areas of marrow edema here in the neck of the femur, or sometimes talus, or head of humerus, or proximal part of the femur. All these areas of marrow edema, if you look classically, they are not at a very classical site. All these, this is not at weight bearing. If it is at weight bearing, we are not so much concerned. It could be particularly in elderly, it could be because of the subchondral insufficiency injury. If it is at the medial cortex of neck, we know that it usually occurs because of the stress injuries. But why is there edema at this some unusual location, which is not classically fitting in the those abnormalities? So whenever you see this kind of appearance, or even in calcaneus, there is a marrow edema in calcaneus, and whenever you see these areas of unusual sites of marrow edema, always look more carefully to look for underlying lesion. Like here, this young boy, 13 years, we saw it in the MR. There is an edema, there is effusion, but if you look at pattern of edema, it is not fitting into the classical stress injury spectrum. And whenever you see this, look carefully for those bones, to look carefully for subtle areas. And if you can see here, there is a small focus of hyperintensity here. Ask for history. That is extremely important. When pain occurs, when pain subsides, if the patient says the pain occurs more at night, subsides on taking medicines, analgesic, and then it reappears again once the effect of medicine is gone, we know that we are dealing with a lesion which is classical osteoid and you can see it very nicely with the help of CT scan. You can see the nidus, you can see the area surrounding it, a small osteolytic lesion with the central nidus, and this is the very classical appearance of osteoid but they can be very much misleading on MR, might be initially thought of as an infective lesion or any other abnormality uh, very frequently, and that is why it is important for us to look for those areas, not just once. We have burnt our fingers multiple times. Again, here, if you look at this femur, patient presented with pain in the hip joint. Again, it looks like a very unusual site of marrow edema. Why should marrow edema occur at the superior part and not here if it is because of the stress injury? And these areas of marrow edema, whenever you see, always look carefully, find out, and you might be able to find a small nidus in this region as here. And that was a small osteoid. Again, similarly, there can be at various sites. I showed you one example of talus, not just the femoral neck. Marrow edema in talus, it can be because of some subchondral insufficiency injury, but it is not classically at weight-bearing region, and it is much more severe compared to that small focal subchondral edema, only on one side. Again, as I said, MR can be sometimes misleading or difficult to detect that small nidus on MR. Whenever you have doubt, at least look carefully or take help of it. This is just a benign incidental lesion, which is not related to this. We know this is a non-ossifying fibroma, right? But whenever you see this, try to look for any area of lesion in between or a small nidus in that. If you can't see properly on MR, it is always better to take help of a CT scan, which will many times show you the lesion much easily and very much clearly. Like here, you can see that small osteolytic area with the nidus, which is osteoid, and that is responsible for patients' marrow edema in the talus as well as the symptoms of the patient. Similarly, in humerus is not a common site for stress injury, but still, whenever you see such kind of significant marrow edema, uh, the nidus is difficult to appreciate again on MR unless you specifically search for it. And as I said, whenever in doubt, it is easier to take help of CT scan, and that will definitely show you that nidus very clearly. Like here, you can see it is a very small cortical lesion, which is here. That is the nidus, and that is responsible for the marrow edema and pain to the patient. So there are multiple examples. I can just show you a few of those more, but I'll show you just one, which is more important, possibly in the uh, when patient present with back pain or leg pain, and again, whenever a young individual, when we get MR spine, you do not find anything abnormal on the T2 weighted images or on the routine MR images. Look carefully on the stir images, particularly in the young individual. Whenever you see any abnormal area or a small focus of marrow edema, look carefully for that. Take detailed images for that. Take fat suppressed eggshell, and what you might see, this is a small focus of marrow edema. And on CT scan, again, this was confirmed to be a small nidus, and this was an osteoid. So don't miss osteoid. Look carefully for the areas of marrow edema, and particularly when they are non-resolving or when they are at unusual site, All these could be because of the small osteodosteoma like here. You can see here there is a very small osteodosteoma involving calcaneum, which is giving rise to the marrow edema. So teaching point two, bone marrow edema at unusual site. It should raise suspicion of underlying lesion. Ask history, pain at the site of edema, pain which is more at night, which is completely relieved by medicine and again occurs, long-standing pain. And as I said, take help of radiograph or CT scan to look for that subtle underlying nidus. Hmm? So this is about the osteodosteoma. Third condition which we see commonly is when the back of a player hurts. You might get sports players, cricketers, bowlers, or football players. They come with the back pain, and what we see is uh, most of them are young individuals. We do not expect too much of the disc-related lesions. There might be some facetal hypertrophy or facet-related changes, but always look carefully at the posterior elements like here, not just on T2, but also on T1 as well as STIR, because these are the sequences which are the marrow-friendly sequences. Whenever there is any areas of marrow edema, they will be far better seen on those T1 weighted images as well as STIR images rather than T2 weighted. On T2 weighted, it will be completely missed, and what you will see is just like a normal marrow or sometimes only some hypointense area, which could be because of the chronic changes. But look carefully on the T1 weighted and STIR images. Sometimes it can be very subtle as this. If you can appreciate, compare on both sides, both the pedicles, compare the right pedicle versus left pedicle at L4 vertebral level, and then look at the T1 weighted images, which are extremely important to detect those subtle changes. Now look at the marrow of L2, L3, and L5, and look at the marrow of L4. It is significantly hypointense on T1 weighted images. It is showing subtle bright signals on the STIR images, and this is the area of marrow edema. That is because of the stress injury. Even the right pedicle, if you look at here, the right pedicle is normal, but the same vertebral level. Look at left pedicle. It is hypointense on T1 weighted, and that is because of the acute stress injury. Never miss this stress injury, particularly in young individuals, because if they continue playing with this injury, what will happen is they will present probably later on with a pedicle fracture or the pars interarticularis fracture, and probably their career will be in the serious risk with that fracture, because then the spine becomes unstable. So it is our responsibility to pick up those subtle areas of marrow edema at the early level so that we can advise them to take rest, to stop the activity for some time, and that will definitely help in healing of those areas of marrow edema. Usually in 4 to 6 weeks times they heal, and then the player can go back to the sports. But if it is missed on the earlier scan and the player continues to play, they invariably end up having those fractures. Like here, if you see here it is involving both the pedicles at L4 vertebral level. Now you can see very clearly there is hypointensity of the pedicle on both sides at L4 level, and that is the acute stress injury, which results in severe pain. Sometimes even CT scan also helps in detecting this subtle incomplete fractures in these players whenever it is there. I'm just showing you subtle changes. Again here, if you see here, compared left and right, on right side, it is showing subtle area of marrow edema. So all these changes, which may not be very obvious, but we need to look carefully, particularly in the players, to detect these areas of acute stress injury. Like here, as I said, T1 is a very friendly sequence where you will see this marrow edema very nicely, and that can be responsible for the severe pain. Sometimes what happens is they might be having acute as well as chronic changes, and those chronic changes are very well seen with the help of CT scan also, where what you will see is there will be areas of sclerosis involving those pars interarticularis or those pedicles compared to the rest of the levels. And that suggests the chronic stress injury. Sometimes there can be incomplete fracture as well. And that is what we are looking for. You can look here, the pars is showing significant sclerosis compared to the other levels, or if you compare it with the other individuals. And that is because of the chronic stress changes, which results in the sclerosis. So look for these acute as well as chronic stress injuries, particularly in players, which can be responsible for the severe back pain. And as I said, we need to detect them early to avoid the fracture of the pars. So this is the sclerotic area, which is because of the chronic injury, while the marrow edematous changes what we saw in the that was because of the acute injury. You can see the chronic injury very nicely here. Right? Uh, as I said, spine of the fast bowler, there is a greater bone mineralization in spine on the contralateral side of the bowling arm. So if the person is a right arm fast bowler, you will see those changes more on the left side. If the person is left arm bowler, you will see commonly on the right side. Even there is some facet asymmetry also on the contralateral side. So on the right-sided right arm fast bowler, you will see mild hypertrophy of the left facet joint, which is like a compensatory change, or you will see invariably in each and every player. The prevalence of injury is very much high, around 44%. They of these injuries, they account the fast bowling injuries, they occur. The spondylolysis and listhesis, they have been reported in almost one-fourth to one-half of the fast bowlers, and even in adolescents, it occur very frequently, and they require quite long time to recover. There are a lot of factors which are responsible, like the bowling action. There are different types of bowling action, and some of them are more prone to the injury. Even the workload and associated injury and age and all those factors, they also contribute to it. And the common site is usually at the neural arch. It occurs at pars intraarticularis. It occurs at the pedicles. It can be bilateral, it can be unilateral, and when it is unilateral, it usually occurs in the contralateral arm. Like here, if you look at the spine, you can see there is a spondylolysis here at L4 vertebral level. Not just that, it is also extending up to the midline, even going opposite side, and there is a chronic stress-related changes in the pedicle also. So all these changes are very typical in the fast bowler, and when, as I said, the acute injury, if is not given rest at that time, then it might result in such kind of fracture and end up having many of the times the surgical intervention. Again, a young bowler, you'll see areas of hypointensity on both the sides. One of them is showing area of edema, and that suggests this is one is acute and rest are the chronic stress related changes. So look for those acute as well as chronic injuries in the fast bowlers, which are extremely important to detect to prevent such kind of fractures, which may occur if they continue playing even with those acute injuries. Again, a young cricketer, there is an acute edema involving the left-sided pedicle of L5 vertebra, and that is because of the stress related changes. On right side, he is already having lysis. On left side, there is an acute injury with subtle incomplete cortical fracture. If given rest at this time, this will prevent spondylolysis on the opposite side, and it will prevent the spine from becoming unstable. If you see hypointensity on both T1 and T2, like here, significant hypointensity, no edema, that suggests these are the chronic changes and not the acute changes. So look for the acute as well as chronic changes. Look deep into the spine that plays, it pays you off. It will definitely help you to detect those areas. Don't ignore those subtle areas of marrow edema. See them on the marrow friendly sequences, which is T1, STIR, or fat suppressed T2. Do not ignore sclerosis, which is hypointense on all sequences, because it suggests chronic stress related changes and it is not a normal spine. Take help of CT scan or have a deeper or more detailed look at the radiograph whenever needed. And missing the injury at early stage, it can result in end of career for the player. So if we don't pay attention to these subtle changes, the player has to pay the price by probably ending his career prematurely. Coming to the fourth dilemma is you must have seen some of the tendons which almost always show as tendinosis, and the supraspinatus is one of them. I'll show you probably on the real life cases that will be much more easier for you to understand. So whenever you have an MRI of shoulder joint, whenever we see the supraspinatus tendon, invariably at certain level, the tendon looks edematous in almost each and every individual, like here. So this case I already showed, patient had Hill-Sachs Bankart, but if you look at this, there is definitely, you can see there is some area of edema in the supraspinatus tendon, and we might end up telling these changes as the changes of because of the tendinosis. But these are not always the changes of tendinosis in every individual. How do we confirm that? It is not that whenever we see this, we can tell them as the tendinotic changes. I'll just readjust the, okay. Sorry for that. So these are the areas of hyperintensity which you will see in the supraspinatus tendon in almost each and every individual. But what sequence is what we take routinely for MR of shoulder? This is the proton density sequences. And we know the PD sequences, they are susceptible to the magic angle artifact. So look at these changes, not just on PD, but always see them on the T2 weighted images also. And invariably, or in many of the individuals, the areas of hyperintensity which are seen on PD, they will not be seen on T2, or they will look as homogeneous hypointense on T2, or even fat suppressed T2 weighted images also. And this confirms that the hyperintensity which is seen here is just because of the magic angle phenomenon, and it is not a true tendinosis. Not just shoulder joint, there are other joints as well where you might see these changes. And one of the joint which is extremely important is ankle joint, because in ankle, as we know, the tendons, they all curve around here. So you pay attention to this tendon, and invariably you will see areas of hyperintensity in the tendon, which looks like it is a tendinotic, it is a edematous tendon. But when you look at other sequence, that is the T2 weighted images, the those areas of hypointensity, they will completely disappear. So on this, it looks like it is a hyperintense tendon. On T2 weighted, you can clearly see there is no abnormal hyperintensity in the tendon, and it is a homogeneous tendon. That is because of the magic angle phenomenon. So keep in mind whenever we are looking at those tendons, one more area where you see commonly as the tendinosis or as the edematous changes is the patellar tendon. So whenever we see at the fat suppressed PD images, you'll always see this area of hyperintensity in the patellar tendon, either at its patellar attachment, sometimes even at its tibial attachment. And this will be seen in each and every individual almost always because of the orientation of the tendon. And these are the areas which we need to be careful before telling them as tendinosis, because these are not tendinosis. As I said, this is the area which is of which looks bright, the area in the patellar tendon which looks hyperintense. But when we look carefully, or when we look even the popliteus tendon many of the times, but when we look it on the T2 weighted images, they look normal, and that is because of the magic angle artifact or magic angle phenomenon, which is an artifact seen in tissues which are having highly organized collagen fibers like the tendons and ligaments, and even sometimes in cartilage. When these tissues are aligned at an approximate angle of 55° with the main magnetic field, there will be increase in the signal in this tissue on the short T images. Which are short T images? They are the T1 and PD and gradient. So most of the tendons, we are looking these structures in the proton density images. Switch over to the T2 weighted images, and you will see these areas of hyperintensity as a normal tendon. And it is not tendinosis, but it is just because of the magic angle phenomenon, and not because of the the abnormality or edema. So hyperintensity which looks bright here, even on here on T1, but on T2 it looks completely normal. So remember the magic of magic angle. The solution is use longer T sequence, which is T2 weighted, where magic angle does not occur, and that will help you, or that will save you from giving the overdiagnosis of the tendinosis. Fifth dilemma is meniscus. Is there always a tear? So I'm showing you a few examples or a few instances, and you need to decide yourself how many of these are tear. So this is the first one where you see such kind of hyperintensity in the meniscus. The second one, again, some hyperintensity in the meniscus. Third one is even larger hyperintensity. Fourth is you are seeing a focal hyperintensity at the posterior part of the meniscus, in the lateral meniscus. Fifth one is hyperintensity, which is seen in the anterior horn of the lateral meniscus, which is seen on the sagittal as well as axial as well as coronal images, all three planes. There is a hyperintensity in the anterior horn of lateral meniscus. Here is a vertical hyperintensity in the posterior horn of medial meniscus. And here is some abnormal shape of the meniscus, which looks like a wavy appearance. And here we don't see meniscus at all. There is no meniscus. So if out of these examples, how many out of these 8 you feel it as these are the examples of tear, and how many you feel that these are just the normal meniscus or at least not a tear and something else? It's difficult for me to take answers of you right now. Maybe we can see those answers, that questions lastly. But none of these examples are showing meniscus tear. All of these are the normal meniscus. If you look here, this is just the normal meniscal vascularity. Same here in young individuals. So we'll see this subtle hyperintensity, which represent just the normal meniscal vascularity. Here there is some signal, but again, this is a degeneration, probably a small area of mucoid degeneration in the meniscus, and we do not stamp it as a tear because it will not be seen on the arthroscopy. The meniscus periphery is all intact. Here, what we are seeing is there is minimal fluid in the popliteus hiatus. So because of the partial volume averaging, it looks like a focal vertical tear, but that is just the normal popliteus hiatus. You can see the part of popliteus tendon which is passing from there, and that is not a tear, but it is just because of the this small fluid adjoining the popliteus tendon in the popliteus hiatus. The fifth one was hyperintensity in the anterior horn of lateral meniscus. If you look carefully, if you trace this, rest of the meniscus is completely fine. What we are seeing is only at its anterior root attachment there is hyperintensity, and this is the normal fleshy attachment of anterior horn of lateral meniscus. This is characteristic of lateral meniscus that it has fleshy attachment at its anterior root and it is not a tear. So please remember, whenever you see this hyperintensity, which is only in the anterior horn of lateral meniscus, which is not horizontal, but it is like a just like the tendons, like we see the subscapularis tendon, which has multipinnate tendon, or any of those structures which have multiple fibers, which are inserting in a broad way, that results in such kind of appearance, and it is not a tear of the meniscus. Here, again, it looks like a focal tear, but if you look carefully, if you look on the sequential images, then you will be able to realize that though the anterior cruciate ligament is injured, what we are seeing here, it is just the meniscofemoral ligament, which is attaching at the meniscus. And just again, because of the partial volume averaging, it looks like it is a tear, but this is a normal meniscofemoral ligament, which can be ligament of Humphrey or ligament of Risberg. And that can sometimes give rise to the appearance of a vertical longitudinal tear, but there is no tear here. Similarly, the wavy appearance of meniscus, this can be just meniscus flounce, and it is not a tear. Here is something which is definitely looking like a tear when we don't see any meniscus, but this patient had history of surgery and partial meniscectomy. So this, which looks like a meniscal tear, is again not a tear. So meniscal tear, what we see is, you know about the different types of tear. I won't go in the detail. Can be vertical longitudinal. Some of them are bucket handle tear, or the horizontal tear with parameniscal cyst, or the radial tear. We know all these types, or even the oblique or flap tears, which reaches up to the surface of the meniscus, can have associated parameniscal cyst. They commonly occur, reach up to the free edge, and sometimes the displaced flap tear. So these are the tears which are having abnormality of shape of the meniscus, not just the signal. Abnormality of signal can be seen in many conditions in meniscus, but whenever the shape of the meniscus is abnormal, that is a 100% sign of meniscus tear. If you look here, the anterior horn is normal triangle. Here, from the normal triangle, a small piece of that triangle is missing. And this suggests there is definitely a meniscal tear, and this is not just the normal vascularity or the intrameniscal degeneration. Again, here, the anterior part is showing triangle. Here, the triangle is blunted, and you can even see the displaced meniscal fragment here. So this is a displaced flap tear. So some of these tears may not show any hyperintensity at all. Like here, the meniscus looks completely hypointense, but look at the shape of the meniscus. It has to be that triangular shape. The triangle is missing. So this at free edge, there is a tear of meniscus, and that torn fragment is displaced in the meniscotibial recess, which is also known as the coronary recess. And that is the classical appearance of displaced flap tear. Again here, both the menisci, they are showing blunted appearance. So we look extremely carefully for the shape of the meniscus. It has to be triangular shape. Whenever the triangle is missing, think about the displaced flap tear. Only thing which mimics displaced flap tear is the partial meniscectomy, where part of the meniscus is surgically removed. So ask for history, and that will help you in diagnosing this condition. One more tear which I wanted to show you apart from all those routine tears is the ramp lesion, which is probably not so frequently reported many of the times, but it is an extremely important tear. These are the peripheral tear of the outer part of the meniscus, particularly the medial meniscus, or sometimes they occur at the meniscocapsular junction. They are almost always associated with the tear of anterior cruciate ligament. So whenever you see ACL tear, then look carefully for the posterior part of the medial meniscus, and many times you might see such tear, which is a vertical longitudinal tear, or sometimes it could be just the meniscocapsular separation. But these tears are extremely important because they can be missed again on MR unless you look carefully for it. Like here, the ACL is torn, and here, if you see, there is a focal fluid signal between the posterior joint capsule and the medial meniscus, and this is a ramp lesion. So you should be knowing about the ramp lesion commonly associated with the anterior cruciate ligament tears. These are the longitudinal tears of the peripheral attachment of posterior horn of medial meniscus, uh, almost always associated with ACL tear. And these injuries, again, they can be hidden during the standard arthroscopic procedures, and they need probing of the posterior horn of medial meniscus. So that is why we need to tell them before the surgery that there is a chances of ramp lesion, so that they specifically look for it and repair those lesions whenever they are doing the surgery for ACL. There are different types of ramp lesion. I am not going in the detail. You can read it easily in the literature, depending on the whether it is a complete or incomplete and what is the location of that tear. But at least remember, we need to look at those posterior part of medial meniscus very carefully, particularly when the ACL is torn. So remember, every hyperintense signal in meniscus is not a tear, and every tear does not have hyperintense signal. Those displaced flap tears, they may not show any hyperintense signal, but only abnormality of shape of the meniscus, and they are the tear of meniscus. Abnormality of shape, it is much more reliable criteria for meniscus tear compared to the abnormality of signal. The signal abnormality could be just because of the normal vascularity or meniscus degeneration, or uh, those intrameniscal degenerative changes or mucoid changes. But whenever you see abnormality of shape, it is definitely a tear. Look for subtle blunting of the free edge, because that is the earliest sign or a sign of a small displaced flap tear. Look for the posterior horn of medial meniscus and its capsular attachment very carefully, particularly in the setting of ACL tear, to detect those ramp lesion, which we need to tell the surgeon to look at them. Coming to the sixth dilemma, that is the anterior knee pain. And again, when the bone, soft tissue, everything look normal, what to do next? A patient who particularly presents with the anterior knee pain and you hardly see any abnormality in the knee joint, look for one thing is the cartilage. You might see those small superficial or a small full thickness fissure in the articular cartilage with subtle subchondral this bone marrow edema. And this is a small grade 4 chondromalacia, a focal chondromalacia, and this could be responsible for patients' anterior knee pain, particularly the patients or the individuals who complain of pain while climbing stairs. Look very carefully for these subtle fissures in the articular cartilage, and which might be full thickness and associated with the subchondral bony changes. If it is extensive like here, it is easier to detect whether it is full thickness loss of cartilage in the larger area, the lateral facet, part of medial facet with multiple bony changes. But when these changes are very subtle, it might be easily missed on the first look of MR, and we need to look carefully for these changes. These are the grades of cartilage injury, which is normal cartilage injury. When you see areas of hyper or hypo intensity, it is 1A lesion. If you see superficial fissures, it is 1B. 2 is again superficial fissures, which are less than 50% thickness. If it is more than 50%, it is 3. Again, here it is more than 50%, which is 3. Or when you see this delamination type of injury, again, it is a grade 3 chondromalacia. And when there is a full thickness defect associated with subchondral bony changes, it is a grade 4 chondromalacia. So this is how we grade the cartilage injury. Another thing that we should look in patient who has anterior knee pain and rest of the MR may not show anything abnormal, look for this Hoffa's fat pad. And many times you might see these areas of edema in the superolateral aspect of Hoffa's fat pad. And this is the appearance of HOFA fat pad impingement. It is commonly associated with the high position of patella, which occurs because of the friction abnormality. Also, there is a condition called uh, when you see the patella alta and a small area of edema between the patellar tendon and the lateral femoral condyle. This is because of the friction of the patella with the of the tendon with the femoral condyle, and known as the patellar tendon lateral femoral condyle friction syndrome, where you will see this small edema in the again supralateral aspect of Hoffa's fat pad, and they can be the reason for patient's pain because there is an abnormal movement of the patella during flexion and extension, which results in rubbing, and there is edema of the Hoffa's fat pad. One more fat pad which might show edema is, we know the fat pad, there are different fat pads in the anterior aspect. There's a Hoffa's fat pad, which is the infrapatellar. In suprapatellar fat pad, it divides into two. One is this one, which is the known as the quadriceps fat pad. Look at the normal fat signal, and here it is replaced by edema. When you see this, this is the appearance of quadricep fat pad impingement. Again, it can be a reason for patient's anterior knee pain. So patient with knee pain, when the MR, you may not find anything abnormal. Before signing it off as a normal MR, look for all these fat pads. Look for the Hoffa's fat pad, look for this quadriceps fat pad, or sometimes you might see edema in this prefemoral fat pad. Again, this is a reason for patient's pain. When you see this prefemoral fat pad edema, it can be because of the abnormal movement usually associated with the patella alta when the patella is higher at position, and that can result in pain to the patient. So do not forget the fat and cartilage. When the bones and soft tissue look normal, look at all fat pads around the knee carefully for presence of edema, and subtle cartilage injury can be missed unless looked upon specifically. So this is the sixth one. Coming to the last, which is the seventh, when the severity of back pain does not match the MR appearance, what to do? Or when the patient presents with a specific radiating pain. For example, sometimes we see even we get the patient with request for the MRI of hip joint or MRI of the upper thigh because patient has severe pain in the thigh. And what we see on MR is thigh is normal. Then we go back to the lumbar spine usually to look for disc. Like here, if you look at the sagittal image, the midline sagittal image, looks like there is some mild bulge at multiple levels, but this does not explain the severe pain that patient has. There is definitely a bulge at L4-5, but look at the parasagittal images or the images at the level of foramen, and you might see a focal disc which is foraminal or sometimes even extraforaminal. So this is a left-sided foraminal and extraforaminal disc. This is significantly compressing the L3 nerve root, and this results in severe pain to the thigh of the patient in the region of thigh. So the pathology is not lying at the thigh, but it is at this level, which is compressing the left-sided foraminal and extraforaminal disc, which is compressing the left L3 nerve root, and which results in severe pain. So even on your sagittal, make sure that you cover a little bit even lateral to the foramen also. The images should not be just from here to here. It should cover the foraminal part as well as one section should go beyond foramen to look for this subtle or to look for this disc, which could be in the foramen or sometimes even predominantly extraforaminal. Remember the neurotomes, what we used to study in the first MBBS, which areas are supplied by which nerve, so that it will be helpful for you to ask the patient about history. And when they give a specific history, you can look for that specific nerve root. So remember about the localization of the disc herniation. It can be central disc, it can be subarticular, it can be foraminal, or sometimes it can be extraforaminal or far lateral disc, which may be responsible for patient's pain. Like here, it looks like at L3-4 there is a bulge, but at L4-5 if you see, it looks like a bulge, but on axial images you can see a component which is in the foramen as well as extraforamen, which is compressing the root. And even at L5-S1 level, there is a large component of disc which is extraforaminal, which is significantly compressing the nerve root. Sometimes like here, it may not be in the central part at all. Whatever we are seeing is it is all extraforaminal. There is a large protruded extraforaminal disc at L4-5 level, and this is definitely causing significant compression of the right-sided L4 nerve root. So look far and wide to detect for the lateral or extraforaminal disc. And this extraforaminal disc, it can be missed, particularly when you don't look carefully for these, or when you look at only the midline sagittal images. So to take home, when the pathology of shoulder, the first pearl what we learned was, when the pathology of shoulder does not look at you, you have to look for it. Look for those subtle Hill-Sachs, subtle Bankart, calcific tendinitis, or those signs of internal impingement. Bone marrow edema, whenever you see edema at the unusual site, it should raise suspicion of the underlying lesion like osteoid Look deep into the spine, that definitely pays you. Look carefully for the subtle marrow edema because of the stress injury, and we need to detect it early and give a rest to the player to avoid the future consequences of fracture of the spine. Remember the magic angle before telling any tendon or ligament as edematous. Particularly in case of tendon, we do come across many tendons, as I showed. They always look like tendinosis, but it is just because of the magic angle phenomenon. So remember to have a look at the T2 weighted images also, and not just the fat suppressed PD or the non-fat suppressed PD images. Every hyperintense signal in meniscus is not a tear, and every tear of meniscus does not have hyperintense signal. It could be just abnormality of shape, which is much more reliable sign for the meniscus tear. Do not forget the fat and cartilage in knee joint. So once you have a look at the ligaments and tendons, the cruciate collateral, after that, even if you are not finding any abnormality or any reason for patient's pain, look carefully for all the fat pads and also for the cartilage for subtle defect or subtle edema, which can be responsible for the patient's pain. And look far and wide to detect the extraforaminal disc, because the central the central images, or the just the routine MR images, they may not show you those extraforaminal disc, which can be a reason for patient's severe pain and nerve root compression. So thank you so much. This is what we had about those lesions. I think we have got some questions.
Yeah, thank you so much, sir. It was a wonderful session. And we have a lot of comments also saying that because it really helps in our day-to-day practice. There are few Q&As. You can also open the Q&A section. I'll also read them out to you.
Yeah, I have already opened. So first is how to differ from subreberal recess. Well, subreberal recess, it usually, if you look at on the superior labrum, the subreberal recess, if you, this is the glenoid and this is the labrum, the recess, it follows the shape of the glenoid. It goes more medially. The labral tears, they go more laterally. They go into the substance of the labrum. That is the characteristic of labral tear. There are many other criteria like measure the distance. If it is more than 3 millimeter, it is usually tear. Recess is usually less than 3 millimeter. Look at the edge. The recess has very smooth edge, while the labral tear is usually a little bit irregular. So that is how we can differentiate between the sublabial recess and tear. And of course, sublabial recess, it has a characteristic location, which is from 11 to 1 o'clock. You cannot have a sublabial recess at entero-inferior labrum, which is around 3 o'clock or 5 o'clock position. So whatever hyperintensity you see, apart from those superior and anterosuperior labrum, they all are labral tear and not variant of the labrum, because variant occurs at the superior and anterosuperior labrum only. Is it necessary to give Hill-Sachs interval in every case? Yes, we do give, and I feel it is extremely useful for our orthopedic surgeons. So we tend to give measure that Hill-Sachs interval in every case, because that ultimately decides the further surgical plan for them. Can we measure Hill-Sachs index and glenoid tract on MRI? Yes, Hill-Sachs index we can easily measure. Glenoid tract also we can measure if we have a proper end-on images of glenoid. The only issue is sometimes on MR the images tend to be a little oblique. So what we see as glenoid is not a clear end-on glenoid view. Or if you take a 3D sequence in MR, maybe that will help you to take a proper end-on image. Now, even with those ultra short TE images, which gives you image just like a CT scan image, it becomes even much more easier to detect those subtle fractures also. So we can surely make it measure it on MR, but because of the on CT we can make those coronal and sagittal reformats much more accurate. Usually the results are a little bit accurate, but again, with a good quality MR, you can definitely measure on MR also. Please explain on track, off track. Again, it will be a little difficult. You can go through the article, but as I said, you measure the Hill-Sachs index, you measure the glenoid tract,
I told you how to measure, draw that line, measure take the diameter of the glenoid, and then you multiply it with 0.83 and and minus the part of the glenoid defect from that. So that will give you the glenoid tract. So so far as the glenoid tract is larger than the Hill-Sachs interval, it is an on-track lesion. But whenever the glenoid tract is smaller and Hill-Sachs index is larger, that suggests that this is an engaging or off-track lesion. Should we report intrasubstantial as grade 1 or grade 2 or just dispatch them as normal? Well, see, when it is a grade 1 signal, we should definitely tell it that it is a signal, but never use the word as tear. Mention it as a grade 1 signal. For grade 2, also mention it as a grade 2 signal. When do we allow it as normal? You will definitely see those subtle linear areas, which is particularly at the junction of posterior horn and body, and that too in the young individual. Those are the normal meniscal vascularities. They may not be mentioned at all, or if you feel the surgeon might feel it as why you have not mentioned, then you can mention it as a hyperintensity, which is likely to be due to normal meniscal vascularity and not a tear, or just as a normal meniscal vascularity, because you don't expect degeneration in the 18-year boy without any reason. But when you see those globular hyperintense areas, which are still within the substance, but they are definitely a globular rounded hyperintense areas, they are the intrameniscal degeneration or classical grade 1 signal. Grade 2 is when it is reaching up to the capsular margin. There is one condition where we can write as grade 2 tear also. That is when it is showing parameniscal cyst, because once the parameniscal cyst is formed, then they are able to see that cyst on the arthroscopy. So that we can mention as a grade 2 tear with the parameniscal cyst. But otherwise, it is only grade 2 signal because it will not be seen on the arthroscopy. Can posterior root tears of medial meniscus be missed on arthroscopy? Root tears are usually seen because that is one area which they can easily see, because it is in the intercondylar region and they can easily see on the arthroscopy. We need to look it carefully on MR not to miss those root tears, because if the meniscus is not extruded, then on sagittal image it might be just one image where you see that torn root. It is just like that ghost phenomenon or the ghost sign, where you are seeing the meniscus and suddenly in one image the meniscus disappears. So look carefully on MR. In majority of patellar cartilage, it seems like grade 1, grade 2 chondromalacia. How to differentiate artifactual high signal from early chondromalacia in absence of subchondral bony changes or thinning? Well, that is because of the normal layering of the cartilage. If you go to the histology of the cartilage has multiple layers, and because of those layers, it look like those subtle. But so far as it is linear and throughout the substance of cartilage, it is just the normal cartilage layering. These one or two signals are the focal areas, which you see as a small areas of degeneration within the substance of cartilage. Again, grade 1 signal of cartilage, it hardly makes any difference whether you, even if you miss it, that is also fine, because it is not going to change much of the management. Two, you can definitely see as areas of fissures and some kind of irregularity of the surface of the cartilage. A few times we encounter significant bulge or compression opposite to side of radiculopathy clinically. How to address such cases? Well, uh, whenever there is no root compression, we need to mention it. Sometimes what we have seen is those could be the older discs and they might be causing the opposite sided nerve roots, which might have settled clinically. But whenever when there is a specific radiating pain on one side, for example, if it is on left side, we need to look carefully at all levels for those foraminal, extraforaminal discs to look for left nerve root compression. Yes, there could be right nerve root compression, which could be larger. But if you ask in detail, patient might tell you that before 2 years he had an episode of pain on the right side, which has now settled. But at least so far as possible, try to explain that left-sided nerve root pain or left-sided leg pain, and in almost every individual you will find some abnormality or some reason for that. Still, there could be, sometimes it could be very like we may not be able to find, but try to find, and in almost, or at least in more than 90-95%, you will be able to see that. Difference between bulge and herniation, I think we already had one session on that about the degenerative disc disease. Bulge is diffuse, which is all around the disc. Herniation is anything which is not bulge is herniation. So herniation is something which is only focal, which is involving less than 25% circumference of the disc. That is called as herniation. But if it is diffuse, which is all around, that is called as disc bulge. Ramp lesion and demonstrate. Ramp lesion is the lesion which is at the which is either a longitudinal tear at the posterior most part or at the outermost part of the posterior horn of medial meniscus, or it is a separation of the medial meniscus from the joint capsule. So it is a meniscocapsular separation, or sometimes just at the periphery. That is classically known as the ramp lesion. Demonstration, I think I have already shown those cases. It will be difficult to go back to those. Maybe I'll try to show. Sorry. So important thing is, because these lesions are sometimes arthroscopically also difficult to detect, that is why it is our even bigger responsibility to show these lesions or to report these lesions so that they are not missed. Like here, if you look at the meniscus, it looks nearly normal, but still we are seeing a fluid intensity signal which is posterior to the meniscus. We know that medial meniscus is very much tightly attached with the joint capsule, and there should not be any fluid here. And remember, this is seen only with ACL tear. So when the ACL is not torn, don't try to override those ramp lesions. But when ACL is torn and you see this area, this usually suggests the ramp lesion. uh, till what age do we see the vascular signal intensity? Well, it depends. It is in the young individual, it doesn't mean that it is seen at 20 and it disappears at 21. It is always a gradual process. But particularly in the young patients, maybe up to the age of 20, even in the later on also, you might see those hyperintensity. It varies from individual to individual. But when you see classically at the junction of posterior horn and body, this is the site where you will commonly see the normal vascular signal, which is not a tear. About the magic angle on posterior horn of medial meniscus, why it is. See, as I said, any structure which is thick with thick collagen, whenever there is an angulation of the 55-degree, that will be seen as the magic angle phenomenon. Posterior horn of medial meniscus, we see very frequently a magic angle. Yeah, usually because of the either degeneration or, as I said, the normal meniscal vascularities. How to account changes in spine not matching with patient symptoms? Changes in the spine not matching with, see, as I said, some of these changes could be chronic and they may not be giving rise to acute symptoms at present, but need to look carefully or need to mention about all those. Mucoid degeneration of meniscus versus normal meniscal high signal, how do we differentiate? See, mucoid is a normal meniscal high signal. I already told you it is young individual, junction of posterior horn body, horizontal only, while mucoid is usually a little globular. Glenoid bone loss percentage, whether more or less than 15%, can be calculated without CT on both shoulder. Is it way to CT bilateral shoulder for all cases? No, as I said, with a good quality MR, with proper images which are obtained perpendicular to the glenoid, you can go away with the CT and give those measurements on MR also. With such lesion percentage, that circle, it is just the best fitting circle. I think it will be again difficult to go back to all those to show those circles, but I think you can easily get that in the multiple articles. They nicely explain those concept of those circle and how to measure that and how to measure all those angles.